Hello everyone and welcome to week 8 and lecture 39 of the knee injury rehabilitation course. Today's lecture is on case-based reviews. We will be discussing the rehab protocol application in elite and amateur athletes. The objectives for today's lecture are to compare rehabilitation priorities in elite versus amateur athletes, to understand how injury management strategies differ based on sports demand, resources, and timelines. We'll also learn to apply evidence-based protocols to real-world cases and scenarios. We will recognize challenges of a return to play in different sporting populations. We'll also try to translate principles of rehabilitation into practical decision making for diverse athletes. So, without any further delay, let's begin. In this lecture, we will see how theory meets reality on the training ground. The same type of injury looks very different in a weekend runner and in a professional athlete. The context shapes every rehab choice we make. Elite athletes focus solely on performance and push the timelines to meet the criteria for return to sport, while amateur athletes and active recreational athletes or individuals balance sport with daily life. Case studies expose these differences in a rehabilitation protocol more clearly than charts ever can. In this session, we will learn through real stories from both worlds. We will be discussing a total of 3 cases in different populations. Let's begin our first case discussion with an elite footballer who has sustained an ACL tear. The incidence of non-contact pivoting type ACL injury in football is very high. Our player here also reports with similar mechanism of ACL tear. He sustains a pivoting injury to his knee without any contact from his opponents. The player undergoes an ACL reconstruction with a hamstring graft. His club expects a rapid return of their key player. Here, the clinician must balance professional pressure for early return with evidence that a rushing rehabilitation or a premature return to play increases risk of injury. The athlete's safety should be the primary concern of any rehabilitation providing team. Now let us discuss in detail the primary considerations in this case. Number 1 is the non-negotiable in this case. The non-negotiable being the criteria-based program. The criteria varies from reduction of initial symptoms of swelling and pain to achieving complete and pain-free range of motion. It also varies with starting weight-bearing exercises and progressing to close kinetic chain exercises to neuromuscular training later in the rehab. Due consideration should be given to other structural injury if present, along with the primary ACL injury. Elite athletes benefit from daily therapy with advanced equipment and a multidisciplinary team consisting of a sports medicine physician, a sports physiotherapist, a strength and conditioning coach, and a sports masseur. Secondly, apart from the exercises required for the rehab of the injured knee, an elite athlete cannot afford to undergo detraining effect for 8 to 9 months of the rehab. Hence, cross training with cardio exercises for aerobic fitness, upper body strength training exercises, core strengthening exercises, and even exercises of the uninjured limb to maintain lean body mass will continue throughout the rehab process. A well-equipped gym with stationary cycles, hydrotherapy pools, and free weights would aid in the component of training. Strength of the injured limb is also tested with the help of isokinetic dynamometer. Running loads are tested with GPS and biomechanics with force plates. Having these equipment is essential in the rehabilitation of a elite professional athlete. Thirdly, even though psychological readiness will be tested during rehab, an athlete may still have other psychological issues related to the injury. Some of them are: will I lose my place in the team? Will I ever play for my club or country again? Will I ever be able to perform on the same level as before? Should I retire from sports and consider coaching? There are numerous such questions in an athlete's mind after injury. Having a sports psychologist on board to deal with such situations would go a long way in making the athlete mentally strong and psychologically ready. Fourth, sports person usually have a very high metabolism due to their training. Post injury, the amount of physical activity reduces, but the metabolism of the athlete remains high. In such cases, it is common for the athletes to gain weight during rehabilitation. Added body weight, or if I may say fat weight or dead weight, would be detrimental to the injured knee during weight bearing exercises. This may cause a delay in complete weight bearing, hence delaying the rehab plan. On the other hand, the athlete requires adequate nourishment in the form of macronutrients as well as vitamins and minerals for healing of the injured tissue. Hence, there has to be a fine balance in the nutrition of the athlete for him to not gain any unwanted weight, but to still have enough nourishment to cater for his injury. This primarily highlights the role of a sports medicine physician and a sports nutritionist. Hence, we can already see that a rehab of a professional athlete entails a multidisciplinary approach. Even with best facilities, criteria for progression in rehab remains the same. On an average, an elite athlete requires at least 9 months post-op to return to play. Objective criteria like more than 90% symmetry on hop and strength test has to be fulfilled. Video analysis of good quality movement while performing sport-specific activities are very essential to prevent re-injury. Psychological readiness can be enhanced by participation in game-like scenarios. For example, in this case, participating in a low-intensity training match or training with less physical teams like the under 19 or under 21 age group teams would help the coach and the team physician decide game readiness. This highlights that evidence and not pressure to play should derive return to play clearance of an injured athlete. Now, after discussing the elite athlete, let us now discuss meniscus injury of a recreational runner. Our patient is a 40-year-old recreational runner who undergoes a meniscal repair. He has limited physiotherapy access and has different goals as compared to an elite athlete. He wishes to be pain free while performing his activities of daily living and while performing light jogging exercise. His rehab plan must be practical and sustainable, with many of the exercises being simple in nature without utilizing much equipment and can be done at home. Meniscus injuries in runners are not unheard of, especially in adults of the fifth and sixth decade of life, and also in individuals who have taken up recreational running later in life. These individuals also suffer from degenerative meniscal changes, and hence recreational running often aggravates their symptoms. Pertinent to note here is the orthopedic surgeon decided to perform a repair and conserve the meniscus instead of performing a meniscectomy. This decision was perhaps influenced because of the desire of the individual to perform light jogging as a part of his lifestyle. Now let's discuss the considerations for a mature athlete. In this case, education and compliance are central for successful rehabilitation of the individual. Without daily supervision, home exercise programs must be simple yet effective. Tissue protection is paramount in the early phase, hence avoiding deep flexion of more than 90 degrees and impact loading to safeguard the meniscal repair is necessary. Weight bearing progression must be gradual, often starting with partial weight bearing and crutches, guided by the surgeon's protocol. Along with gradual weight bearing progression, rehab must focus on early restoration of full knee extension alongside progressive lower limb strengthening through close chain low load exercises, and also integration of proprioceptive training to ensure joint stability without overstressing the repair. Running is delayed, typically not before 4 to 6 months, and it must be preceded by functional testing for strength, for hop symmetry, and pain free range of motion. The goal in this case is to return to pain free recreational activity and not elite performance. So, load management and patient expectations are crucial. In this case, cross training can also be undertaken with the help of cycling, pool running, swimming, and should maintain cardiovascular fitness without excessive joint loading. Education on long term joint preservation is key. Weight control, footwear, surface choice, and avoiding repetitive high impact loads reduce risk of osteoarthritis. Psychological reassurance and setting realistic expectations help maintain compliance. Success is defined as safe return to recreational running and not necessarily pre-injury mileage or speed. Functional progress is monitored with basic tests like single leg squats or step downs. Progression is slower in this case but focus on long-term knee health. Criteria for clearance include full range of motion, pain-free activities of daily living, and strength symmetry approaching 90%. The ability to jog without pain is a key functional milestone. Jogging or light running usually resumes by 4 to 6 months post surgery if the criteria for progression and rehab is met. Amateur athletes often progress more conservatively because there is no pressure for an early RTP. Unlike the return to play of an elite player, the return to play of an amateur athlete or recreational athlete is not supervised by a coach or a physician. Hence, the return to play in this case is guided by the symptoms experienced by the athlete himself. The progression from return to activity to return to play should be very gradual and can be guided by using a universal pain assessment tool similar to a visual analog scale for pain. Here, an athlete grades the pain on a scale of 1 to 10, 10 being the maximum unbearable pain that the individual experiences. A third and final case is that of an elite wrestler who has sustained a multi-ligament injury involving the ACL, the PCL, and the medial collateral ligament. He required a stage surgery and after the surgery has now come for rehab. Wrestling as a sport has two categories. One is the Greco-Roman and the other a freestyle. Both these categories demand intense knee stability, making this rehabilitation in this athlete a tough challenge for any rehab team. Rehab in this case will be long and with no guarantee of full return to pre-injury levels. The challenge is conflicting protocols. In this case, one graft may need mobilization while another requires protection. Protection of multiple graft is of the highest priority. The knee must be braced to prevent valgus stress for the MCL, posterior tibial translation for the PCL, while respecting the ACL healing timelines. Range of motion must be restored cautiously. Aggressive early flexion can stress the PCL, while failure to regain extension risks stiffness and arthrofibrosis. Weight bearing progression is usually delayed and highly individualized as simultaneous ACL and PCL reconstruction require stricter load protection. Quadriceps activation is critical. Quadriceps are the primary dynamic stabilizers for the PCL and must be retrained early with isometrics and neuromuscular stimulation. Hamstring strengthening is delayed since hamstring contraction can increase posterior tibial translation and jeopardize the PCL graft. Rehab often extends beyond a year. Apart from these, most considerations of the elite football player that we discussed in case 1 and of the elite wrestler in this case with regards to psychological state, nutrition, and of presence of a multidisciplinary approach remains the same. Despite resources, functional recovery may remain incomplete in a case of this wrestler. This highlights the limitations of medical science in complex injuries. There are key differences in the psychological and social factors of an elite and an amateur athlete. Elite athletes face career pressure. Their financial life is at stake and they are under constant media scrutiny. Amateur athletes face job demands. They have limited leave from their work and they have family pressures and family to attend to. Both groups share fear of re-injury, and a subsequent injury would require a longer layoff. Psychological support, goal setting, and expectation management are as important as physical rehabilitation in both the groups. The cases discussed today teach us that while principles of criteria based rehab apply universally, the context shapes application of the rehab protocol. Elite athletes benefit from the resources but face pressure of an early return to play, while amateurs progress slowly but without much supervision. The key message through these cases are to adapt to the protocols and understand athlete context while holding firm to the evidence-based criteria. Hence, I still maintain that rehab protocols should be used more like a guideline and modified according to the patient goal and expectation. However, there are some key differences in rehabilitation between elite and amateur athlete that I would like to highlight now. First is the primary goal. In elite athlete, the aim is a full return to pre-injury performance level. In the amateur athlete, the priority is safe participation in a recreational sport and long-term joint health. Second, the timeline. Elite players often follow an accelerated rehab pathway under close monitoring by a multidisciplinary rehab team. Amateur athletes usually follow a conservative plan, taking longer time with more focus on tissue protection. Third are the resources. Elite athletes have access to a multidisciplinary team of surgeon, physician, physiotherapist, strength coach, sports scientist, etc. Amateurs typically have access to only a physiotherapist with much of the rehab done through home exercises. Fourth is the monitoring. In elite rehab, objective testing is advanced using isokinetic testing, GPS tracking, and biomechanical labs. In amateur rehab, progress is measured using simpler tools like handheld dynamometer, hop test, and clinical assessments. Fifth is the risk tolerance. Elite athletes often accept a higher risk of early return because their careers and contracts depend on fast recovery. Amateur athletes adopt a lower risk approach, delaying return to play to avoid re-injury and reduce the chances of early osteoarthritis. Sixth, the long-term focus. For elite, the emphasis is on a rapid return to competition while maintaining ongoing injury prevention programs. For amateur athletes, the long-term goal is joint preservation and maintaining the ability to enjoy sport and daily activities without any pain. With this, we come to the end of this lecture. The key takeaway messages are: even though protocols must adapt to athlete context, the evidence-based criteria apply universally and should be followed in each case. We have seen the key differences between elite and amateur athletes. Multidisciplinary support enhances outcomes of the rehab program. Case-based learning bridges theory and practice, and hence more such cases should be discussed among colleagues of different disciplines to understand different perspectives better. These are some of the references that I have used in today's lecture. With this, we have come to the end of lecture number 39, and we will progress to lecture number 40 in the next class. Thank you for your time. Have a very good day.